Parotitis, the 4th, November 21st, 2024. And the focus in this one would be facial paralysis in a case of Sialolithiasis-Induced Recurrent Parotitis. Key point to take home here is that facial paralysis, which manifests in facial muscle weakness and sensory disturbance, that is numbness, paresthesia, etc. of the face, especially unilaterally, has multiple causes, a lot of causes, such as trauma, Bell's palsy, which is any form of facial nerve inflammation that is unilateral and does not involve the central nervous system, that causes facial paralysis. Stroke also, autoimmune disorders, tumors, and rarely recurrent parotitis itself, amyloidosis and sarcoidosis can also cause facial nerve paralysis. Recurrent parotitis of any cause can cause parotid gland swelling, and that can compress the facial nerve, especially of the mandibular branch, because the branch of the facial nerve that goes through or around the parotid gland is the mandibular branch of the facial nerve, supplying the muscles and dermatome or sensory function of the lower face. And in this patient, in this case report, who experiences recurrent parotitis after a trauma, or should I say, the patient has been experiencing recurrent parotitis. However, this is especially exacerbated after a trauma to the right face, followed by facial paralysis, upon which investigations and clinical examinations revealed a worsening of the sialolithiasis that he had, and procedure to remove the sialolith resulted in complete resolution of the facial paralysis without any recurrence. The risk factor for sialolithiasis itself include dehydration, higher calcium content in the saliva, obstruction of the parotid duct or the salivary duct, which all of these results in salivary stasis, meaning the outflow is slower or even blocked, resulting in higher propensity to develop concretion of the saliva. That is the saliva drying out, leaving a hard or solid sediment that can build up into a stone. The conservative treatment for sialolithiasis include NSAID as an anti-inflammation and painkiller usually, and salialogogues to improve the outflow of the saliva, hoping it will slowly shrink and then remove the sialolith or the salivary stone. The definitive treatment for sialolithiasis is lithotripsy, which is breaking down the stone into smaller pieces and making it easier for them to get out of the salivary duct or to be removed surgically. Facial palsy or paralysis, as we have mentioned, it has a lot of possible causes, including Bell's palsy, stroke, autoimmune conditions, Lyme disease, which is a tick-borne illness, Ramsay-Hunt syndrome, which is a complication of herpes simplex virus infection that attacks the facial nerve and thus causing facial paralysis. And it can also be idiopathic, meaning no cause, no pathophysiology was identified. And it could also be caused by rarer etiologies such as recurrent parotitis, abscesses, tumors, amyloidosis, or sarcoidosis. Parotid sialolithiasis itself contributes to 15% of salivary stone cases, where salivary stones not only can occur in the parotid duct, but it can also occur in salivary duct of other salivary glands, such as the submandibular salivary glands. And When it occurs in the parotid duct, which is termed parotid sialolithiasis, its incidence is rather rare, that is 1 out of 30,000 individuals. The symptoms usually involve pain, swelling of the same site, and parotitis itself, and sometimes it is a recurrent one because it often causes blockages that returns, that keeps happening over and over again. In this case study, the patient is a 56-year-old male with a history of sialolithiasis-induced recurrent parotitis and recent bilateral Botox injection to the forehead. This patient presented to the emergency room with 4 hours of facial paralysis that resulted 1 hour after waking up, after sleeping on the opposite side, so on his left side. So it is unlikely that pressure during sleep causing the recurrent parotitis or the pain that the patient experiencing or the facial paralysis. There was also a history 4 days ago where he fell into the ground at walking level due to slippery ground, and he lacerated his right eyebrow due to the fall. However, at that time, no facial nerve dysfunction was noted. No drooping of the face, no impaired sensorium, no paresthesia, no numbness of the face. And there were also no recent signs of infections, and workup or investigation had revealed that there were no other possible cause of recurrent parotitis such as tumors, HIV, primary hyperparathyroidism, tuberculosis, autoimmune disorders other than the sialolith causing the recurrent parotitis. The neurological profile of this patient, there was a sensory deficit on the right side of the face, of the entire face, and there was also motor deficit involving the lip on the right side of the face, causing the patient to have difficulty smiling on the right side of the face. And this is equivalent to House-Brackman score 3, which is this moderate dysfunction of the mouth area due to facial nerve injury, where there is obvious but no disfiguring muscle weakness. It was rather difficult to evaluate directly whether there is a forehead motor deficit or not because of the history of Botox injection to the forehead. And taste sensation of the third front of the tongue is also mediated by facial nerve, and it was intact, so no deficit in that area. There were also normal motoric strength of all limbs, which is against the differential diagnosis of stroke, and also no cerebral dysfunction, which further supports that notion. And deep tendon reflexes are normal, meaning it is most likely a lower motor neuron injury, does not involve central nervous system. So this also supports the absence of stroke as the underlying cause. And the lips that are difficult for the patient to smile, this points to the location of the facial nerve injury, that is on the mandibular branch of the facial nerve. Meanwhile, the zygomatic branch, which is higher than the mandibular branch but lower than the temporal branch that innervates the forehead, the zygomatic branch of the facial nerve was found having intact motor function because the patient can actually resist the examiner's attempt to force open their eyes. So the forehead involvement is unlikely, even though it's hard to evaluate. But based on these results, it is interpolated that the temporal branch is unlikely to be involved. And the evidence about other differentials. The recent facial trauma can exacerbate the recurrent parotitis swelling, therefore easier for it to cause compression of the facial nerve. And the sialolithiasis also promotes the recurrent parotitis, which can compress the facial nerve, and no history of herpes simplex infection, therefore against Ramsay-Hunt syndrome. No recent history of travel, tick-borne illnesses, tick bites or rashes, which is against Lyme disease, and no headache, which is against a complex migraine that may manifest with motor and sensory deficits. Head MRI ruled out stroke pathologies, and neck CT without contrast revealed a stone that, when compared to neck CT that is performed 6 months ago, it showed that the stones actually got larger this time and moved a little bit anteriorly, making it likely that it actually now caused obstruction compared to 6 months ago. And there was also dilatation of the stasis duct in the current CT scan of the neck, which further supports that this is actually a recent blockage. Unlike the previous recurrent parotitis, this one is actually more severe and may induce the facial paralysis, which may also result or exacerbated by the trauma to the right side of the face 4 days ago. And follow-up MRI was deemed unnecessary because soon there was already an appointment for the stone removal by an ENT. 4 hours later, after observation in the emergency department, the symptoms improved but not yet resolved. And after appointment with the ENT and removal of the salivary stone, the facial paralysis resolved completely without recurrence. This is the depiction in CT scan of the neck, where the red arrow points to the sialolith, and the yellow arrow points to the dilated stasis duct, which signifies an obstruction. And the left image would be the current admissions CT scan. The middle is the CT scan of the neck 6 months ago, and the right image would be the anatomical depiction of the facial nerve and its branches that innervates the face. When compared the middle image to the left image, it's visible that the left image, which is the current image, the most current CT of the neck, it shows that the stone actually moved anteriorly and is now larger. The risk factor for sialolithiasis for the formation of salivary stone include dehydration, blockage of the salivary flow causing salivary stasis, increased calcium content in the saliva, and recurrent parotitis itself. And the conservative treatment include NSAID for anti-inflammation and painkiller, and sialogogues to improve the outflow of the saliva. Definite treatment for sialolithiasis include lithotripsies, which can be performed through extracorporeal shockwave lithotripsy or laser lithotripsy that is used to break down the stones into smaller pieces, making it easier to get out themselves or to be taken out through surgery. The surgery itself includes endoscopy or video-assisted sialothectomy, which is a last resort because it's the most invasive of these treatments. Endoscopy is usually reserved for stones that are easier to take out through endoscopy, that is, having size of under 7 millimeters and mobile, such as in this patient. The complications of parotid stone removal surgery include injury to the surrounding structures, including the facial nerve, the salivary duct itself, and it does not exclude the possibility of post-surgical side infection or recurrence of the sialolithiasis. Thanks for watching.